happy we have different programs, but one of that is very close to our hearts is elimination of mother-to-child transmission of HIV. This has been a very, very long journey, one that has high points and low points, challenges and successes. And the approach that we're going to discuss this afternoon or this evening is one that brings on implementation research. We have to speak to us this evening Professor Sarah Gimbel. She's a professor of nursing and global health at the University of Washington. She's also been very active in implementation research. We have implementation research where we bring the innovations to the field. Her experience is in maternal child health, primary health, HIV prevention, and she's worked in different countries, including here in Kenya, Mozambique, and Cote d'Ivoire. She's developed and tested interventions to strengthen health systems, to improve the reach and quality of reproductive and child health services, both preventive and clinical. And one of those is the SIA, which is a systems analysis improvement approach. So I'd like to welcome Dr. Gimbel to take it over from here and give a presentation. Welcome, Sarah.
Great, thank you so much. I was hoping to share my screen. Let's see, I'm gonna do screen two. I'm going to see, does this work for everybody? How's that? Does everyone see a big blue screen there?
Yes, we can see it. And for the audience, just be free to type in your questions under Q&A or the chat box. We shall look at that at the end. Please.
Great, yeah, Dalton, if you can keep an eye on that, that would be so much, so helpful. Thank you so much. So as Dr. Dalton was saying, today I will introduce the Systems Analysis and Improvement Approach, or what we call SIA, which is a systems engineering approach to optimize health service delivery. For the content of today's presentation, I'll talk a little bit about systems engineering in health systems. I'll talk about the SIA and its core components, cascade analysis, process mapping, and CQI. I'll talk about why it works, where it works, and excitingly, I'll talk about all the experiences from Kenya using the SIA. So let's do a group poll. Who, maybe we can just kind of note down, jot down on your own piece of paper, who here has experience using quality improvement in a clinic context? Who has experience using quality improvement in a research context? Who has experience making a decision about resource allocation where there are two or more options where you could get the same result? Who has worked with a partner, a government or an NGO, who has to decide how to allocate limited resources? Who has had an experience of trying to diagnose and fix a problem on a project or team system? Yep, people are raising their hands, right? Who has an experience, who has chosen their study area or topic based on diagnosing a need versus choosing based on convenience or past experience? So what kind of decisions do we make in public health? Where to provide the COVID vaccine, how to staff a community outreach team, where to build a new hospital, how to organize a newly integrated service flow, how many test machines and cartridges to buy and where to place them, how many people to admit to the emergency department before referring, when to commit to an imperfect vaccine for scale up, whether to scale up home or clinic-based data sample collection for screening. What kinds of factors influence these decisions? There's cost and coverage and uptake and feasibility, acceptability, harm, time, equity, quality, waste. It can be overwhelming. So why not just try and see? Why doesn't it make sense just to wait and see? More specifically, why not commit to a decision early and then change later in the course? Or why not just wait until one option appears to be clearly superior to another and then decide? So I borrowed this slide from a guy named Joe Heim at the University of Washington, who works in computer science and engineering. And we call this the getting smarter faster or reducing unknowns slide. So if we think about making smarter decisions faster, you need to look at this slide like life. At the beginning of it, on my far left, you're a young adult when you start going on dates. So this is life, right? You're a young adult, you're going on dates, and you're learning slowly what you want in a mate, and eventually you marry. Or you could look at it this way: university, you take classes and you're trying to figure out what you're really passionate about. What kinds of decisions do we make in public health, where we're trying to make these hone in on our decisions? How do we organize new services? How do we implement new strategies? Where to provide this new vaccine, or how to staff the outreach team, when to build a new hospital, et cetera, et cetera. There's so many factors that can influence these decisions. And so systems engineering is helpful because it provides models to help us guide our decision making. These models help increase access to critical knowledge so you can pin down what is working best earlier and allocate your resources earlier to get the most impact and success, right? So it can flatten your curve. Now, certainly decisions in complex systems can be complicated, but it's important to keep in mind that using a try and see approach can waste limited time, resources, and the will of your teams. And using systems engineering tools that are built to model complexity and engage knowledge of healthcare teams can make decision-making easier. So systems engineering seems like a big word, but it's a field like any other. It arose in the early part of the last century, mainly in response to increasingly complex industrial systems, such as telecommunications, military, and aeronautics. Systems are defined as collections of interdependent elements, or components which share or contribute to a common purpose. One well-known systems engineering model is the Toyota production system, which we also know as Lean, or the Lean model. Toyota, as in the car manufacturer, developed this model to produce its cars more efficiently with higher quality over time. And the model focuses on reducing error rates within production systems by identifying and eliminating sources of waste. So the systems engineering can be used in global health contexts to optimize health services. And there's sort of three main components. One, these include diagnosing problems and identifying needs. Two, evaluating decision options to address selected problems through modeling and optimizing. And three, translating these findings into practical recommendations or actions. SIA is a package of systems engineering tools that include cascade analysis, process mapping, and continuous quality improvement. And SIA is particularly well suited to facilitating process improvement in chronic care delivery systems. So SIA was originally developed to optimize the prevention of mother-to-child transmission of HIV care cascade in central Mozambique. That's when it started. The SIA is an intervention that is implemented at the facility level, or in some cases, the community level. The core steps of the SIA approach include: one, use of a cascade analysis tool, which I'll describe shortly. Two, conducting process mapping at the site level. And three, subsequent identification, definition, and implementation of a workflow modification. Four, after a specified period of time, an assessment of the effect of the workflow modification on the care cascade. And five, repeating the analysis and improvement cycle over time. So we can see the 3, 4, and 5 is sort of synonymous with continuous quality improvement, right? These steps are meant to occur chronologically and repetitively over time. So to begin, one must first decide what care cascade is your focus. The SIA has been introduced in a range of care cascades, including the prevention of mother-to-child transmission of HIV, malaria, hypertension, schizophrenia, and many, many more. Once the care cascade has been selected, one needs to ask, one, what are the essential steps a patient takes to be screened, diagnosed, treated, and sustained in care or linked to a referral service? Two, what data sources already exist to capture these steps? Try to use routine data sources, not invent more work for ourselves. We collect plenty of data. Three, who are the key stakeholders who need to be brought in to identify these steps and their defined data sources? Now we will discuss this process with the PMTCT care cascade. So I'm sure I'm talking to all the experts here, but we'll just go over it because it is a surprisingly complex care cascade, the PMTCT. So our patient passes through 3 distinct biological phases: antenatal care, peripartum, and postpartum. The patient obtains healthcare services across 3 distinct areas of the health facility: antenatal care, maternity, and at-risk childcare. And these services may or may not be located close to one another at the facility. Finally, it's a very lengthy cascade from start to finish, close to 2 years. There are various activities that occur across each of these steps, as well as we can see in this slide. So understanding the health service and defining the care cascade steps in your health service of interest is critical to building your cascade analysis tool when you adapt SIA to your work. So using the information garnered during the stakeholder engagement process, we then define the patient care seeking steps and the associated routine data sources. The steps of the cascade should be sequential and linked. This means the patient needs to pass through the steps to get to the subsequent step. Once those steps are identified, it is necessary to identify existing data sources with routinely collected data. Rather than introduce additional data collection requirements, we look for what is already collected. Once the sequential steps with the sources are identified, the CAT is developed in Excel generally. In brief, a cascade analysis tool allows health workers to input regularly collected health facility level data into an easy to use Excel-based tool that provides them with a view of both the number and proportion of patients passing through each step of the care cascade and the potential cascade gain there in red. You can see if the gap at each step was eliminating, keeping all other steps constant. So here the cascade gain, so here the cascade gain, you could say in another way, the cascade gain demonstrates the potential number of beneficiaries if the proportion served at a specific step reaches 100% while keeping all other steps constant. In American English, we say where we get more bang for our buck. In this way, the healthcare worker can make the best decision as to where they should target their quality improvement efforts. So this is an example. This example is the Excel-based PMTCT cascade analysis tool, or the PCAT. In this figure viewing of the PCAT, we can see boxes on the left which represent the steps of the PMTCT care cascade. In reality, the PMTCT cascade is actually 2 cascades. The first is from first antenatal care visit through the administration of antiretroviral prophylaxis to the newborn in the maternity. The second cascade follows from when the HIV-exposed babies are enrolled in at-risk care services at their local health facility to HIV-diagnosed children then initiating ART. The number under each of these steps represents the data inputted by the health worker when using the tool and comes from routine monthly reports. For example, once the potential denominator is estimated using census data, we have the number of pregnant women expected to arrive in a given period. The healthcare worker then completes the tool. The healthcare worker completing the tool then inputs the number of first antenatal care visits during the time period of interest. It's typically a month, but it can be a week, It can be 3 to 6 months, depending on how your data is collected. The PCAT automatically calculates the percent of the total who reach this desired step. Next, the number tested for HIV is inputted again, and the percent of the total who reach this step is calculated. Each of the steps identified in the PCAT exist within routinely reported health information systems. Those steps which are modifiable, meaning they can be changed through the efforts of the healthcare team at the front line, also include an optimization function. That's the part here in red, which demonstrates the potential cascade gain if the percent of the step reaches 100%, keeping all other steps constant. The results of optimization, again in the red text, communicates to the healthcare staff where quality improvement efforts should be targeted. So once the CAT, or the cascade analysis tool, is used and the primary bottlenecks are identified, then the healthcare team will have a better idea of where patients are being lost along the care cascade and which steps should be targeted to make the most impact. The next step is to draw a process map to identify the steps patients take in the health facility. In SIA, the study team works together with the health facility staff to map out the current patient care pathway. Again, these are the steps that the patient takes to get through their systems. Oftentimes, as a nurse, I know we're always thinking about how we're organized, how we're setting up our systems. But in SIA, we really want to focus on how the patient care is occurring. What is the current patient care pathway? So remember too, that this is meant to be an actual care pathway, not what the norms or the protocols say should happen, but rather what is currently happening for patients as they pass through from screening, diagnosis, treatment, management, referral, etc. A typical hand-drawn map is above right. They're often messy and corrected numerous times. Once a map is finalized, then areas where change or improvement is possible. Is identified, and the computer-generated map, along with located on the bottom left of the slide, relays similar information and was made with a computer program called Visio. You could also use Lucid. In any event, both handwritten and computerized versions work. Even a flip chart paper mounted on the wall can be used and then updated monthly during supervision visits, which is truthfully the most common way that I've seen it used. Computer-generated versions do have the added benefit of being able to use colors to demonstrate different services across the cascade. In this case, we see distinct colors for specific sections: reception, antenatal care, laboratory, social work, etc. It seems like somebody raised their hand. Is there something, question that's in?
Yes, John, put your hands up.
Hi. Or maybe that was an error. Okay, well, let me know if you have a question. Feel free to just chat, that's fine. So finally, the third component, the results of the cascade analysis and the process mapping allow healthcare teams to identify and prioritize areas of focus for that next step, continuous quality improvement, which I know many of you have probably had experience with. Sometimes this is referred to as the plan, do, study, act cycle, which provides space for healthcare teams to review their systems level findings and then design and test specific workflow adaptations, monitor changes in performance, initiate additional iterations, and repeat the analysis and improvement cycle. SIA is not a one-time thing. It's not an intervention you do one time. It is meant to be ongoing and support a culture shift in how healthcare teams view their care systems and use data to drive improvement in their healthcare delivery. I'd like to emphasize that SIA is an evidence-based intervention that was tested partly in Kenya. In 2014-15, it was rigorously evaluated in a 3-country cluster randomized control trial in Cote d'Ivoire, Kenya, and Mozambique. The SIA intervention was implemented by study nurses and resulted in significant improvements in pregnant mothers accepting ART, from 13.3% in intervention sites versus 4.1% in control facilities, and significant improvements in early HIV diagnosis in infants within 8 weeks of life. Intervention facilities improved 11.6% versus less than 1% in the control sites. We also have been exploring how SIA works. The theoretical underpinnings of the SIA lie in Itzhak-Ajin's theory of planned behavior. Ajin's theory stated that behavior change was always preceded by an intention to change. Intention to change then is driven by attitudes, subjective norms, and perceived behavioral control. In this slide, we have mapped the SIA activities directly to the outcomes of improved clinical knowledge attainment, improved prioritization of bottlenecks, strong team consensus building, as well as assurances of adequate resources. And these outcomes allow for Ajin's prerequisites to be met, to move to intention, and then on to change in care cascade performance, and ultimately to improve clinical outcomes. The measures we used in SIA, in the PMTCT SIA work included both process and clinical outcomes, and this is typical for SIA. The process measures logically map to the key steps of the care cascade, right, to the PCAT, and include percent of pregnant mothers HIV screened, percent of HIV positive pregnant mothers treated, percent of HIV exposed infants screened. And relevant clinic outcomes include percent of mothers with suppressed viral load and the rate of HIV transmission between mothers and babies at 6 months postpartum. We also show here some examples of the type of microinterventions that have been implemented by different facilities, as well as the resulting process improvement. We classified post hoc activities under specific categories of type of change. For example, changing CD4 blood count, blood draws from weekly to daily was classified as a system reorganization type of change. That specific activity resulted in an increase in HIV positive moms with CD4 from 26 to 56%. A second activity where maternity tours are provided to antenatal care patients was classified as expanding patient provider knowledge and resulted in a 16% increase in institutional birth. And a third activity was to have ANC nurses pass by the laboratory to pick up results versus waiting for the lab workers to bring them back to the ANC nurses. We classified this type of change as improving communication across the healthcare team, which resulted in a reduced lab return times from 6 weeks to 10 days, and so forth. In summary, providing health workers and managers at the front line with a systems view can highlight inefficiencies at each step of the cascade, better explain how steps interrelate, and foster novel, iterative, and team-based approaches to improve healthcare delivery and identify best practices for scale-up. The SIA was designed to improve this picture and ensure that patients receive the services they need. So SIA is currently being tested across numerous contexts, both geographically and clinically. Generally, studies start by adapting SIA to a new area, then determining the adaptation's efficacy, studying scaling, and we are now just developing a proposal to assess its sustainment when fully supported through the Ministry of Health. You can see here we have PMTCT, hypertension, family planning, cervical cancer, mental health, pediatric HIV, naloxone, which is a drug that we use when people are overdosing on opioids, malaria, and juvenile justice. We're working in juvenile prisons in the US. There are also new projects that are being developed specifically to optimize prevention and treatment of type 2 diabetes, tuberculosis, and assisted partner HIV services. I'd like to call out the Kenyan experience with SIA because you all have been such leaders in this work. Much of the SIA has been developed in consortium with scholars, leaders, and frontline healthcare teams here in Kenya. The original SIA cluster randomized trial was conducted partly in Kenya under the leadership of Dr. Ruth Ntwati, who went on to support the development of a phone-based app for the PCAT, which is available on Google Play Store, as well as adaptation of SIA for the pediatric HIV diagnosis and care cascade. And in Mombasa, much SIA work has been ongoing since 2016 with a SIA adaptation to optimize HIV testing at family planning clinics, as well as to assess its effectiveness in increasing cervical cancer and screening. And I know there's just too many people to name who've been involved in all of this work, but the study teams, the MOH partners, frontline healthcare teams and communities throughout Kenya, Mozambique, in the US, in California and Washington State, and then in the Democratic Republic of Congo, and all of the many donors. We do have a website that you're welcome to access. There's tools and resources available there, as well as descriptions of all the different projects. And that is, that's the end of my presentation. So I'd love to take questions. I hope that wasn't too long. I wanted to make sure to have time for it so we could chat.
Thank you very much. Thank you, Sarah, for that clear talk. And I think there was a question. John Boothia, you had raised your hand, and I think now you've been unmuted. You can go ahead and ask your question or make your comment, Dr. Boothia, and the others as well. I can start with Boothia. We also have others. Can Secretary,
oh,
please?
now I can see the questions. Let's see. Okay, I'll go to the top. So we'll try to go to
So
the top.
we have John Boothia. We also have Benta Omonge. Go ahead and ask your questions.
In slide mode. Oh, are you seeing? I think I'm on the wrong one then. Here, sorry. I guess I presented on the wrong slide. So you all are seeing. It's too bad. Okay, Collins. But let's just answer questions then. Collins. All right. Well, I see a question from Cynthia Rona. What should happen in a case where you introduce formula milk in an exposed baby? This is because the baby was abandoned, mother found later after weeks, found to be known positive, had done breastfeeding before she abandoned the baby, but then she would want to do exclusive breastfeeding. How do we go about that? Well, that is not a question that I am qualified to respond to, because I'm not working in the Ministry of Health, who sets the guidelines for Kenya. The SIA is more of a tool to help the frontline healthcare team figure out these sorts of questions together about where they'll access that information. But that is a clinical question that I think would be, I would defer to those who have more knowledge of the Ministry of Health guidelines for this sort of introduction of formula milk. Sorry about that. That's not my wheelhouse. Okay, I have a nice question from Elizabeth Arungo. Hello, and thank you for an interesting presentation. Does the approach for SIA similar to a theory of change in the European systems? Is the approach for SIA similar to a theory of change? The discussion seems to have, so a theory of change, SIA is an implementation strategy. It's an evidence-based implementation strategy. A theory of change is basically understanding why something works. And I would say that SIA is something that would help you get to a theory of change about whatever your specific problem is, but it is not a theory of change. I'm happy to talk about theories of change at some point and how to conduct them and identify them. I enjoy theories of change very, very much. And I encourage all of my students to use that in order to sort of justify whatever interventions they're proposing in the public health setting. That's a great question, Elizabeth. I have been following for the last 3 months, no CB points. Nope, these are something about points.
There's a question from Professor Bimbo about SIA in TB. Maybe if you could just comment on that for childhood tuberculosis.
Oh, is there? I'm looking for it. You feel free to just speak. That's fine.
Hi. My name is Lisa Obimbo. I'm a pediatrician and an epidemiologist. I'm also a pulmonologist, so I have lots of interest in TB and TB-HIV. So during your lecture, you mentioned that there's some ongoing SIA project or research around the cascade for child TB. And I was just wondering if you could give us a little bit more detail. Is it something that's ongoing, or is something that has already happened, has been published? Yeah, just if you could give us.
Yeah, great. The work that's being done is actually not pediatric specific TB, although peds are part of it. It's in the area of Cape Elizabeth in South Africa, where they're exploring TB and community identification of family members using a specific strategy. So it's sort of community-based identification of at-risk TB. And they're using people who are identified in the system and then going out to their families and houses. And they're trying to use SIA in order to improve the efficiency of that work. But if you're interested, for example, in applying SIA or thinking about SIA and creating a cascade for clinical care within the health system, that would be novel. That's an area that no one has taken up yet. So I'd be happy to speak with you about that if you're interested. I certainly think that TB is well placed for it because the data, all the cascade data is actually collected. So building the cascade is generally the more complicated part of the process of adopting SIA. The process mapping comes really naturally to healthcare teams. But if you're interested in that, I would be happy to speak with you further. Any other questions? I usually get a lot more questions, but I guess people
Collins and Cornelius, you may unmute and ask your question.
Professor Amalwa, we also have a question from Elizabeth Irongo. Elizabeth, kindly unmute and ask your question. Thank you.
Hello, Sarah. Thank you for the opportunity to ask. I was asking because sometimes when we use the theory of change in implementation science, it's either that you have a simple problem that has a linear causality, or the second case is that you have a problem that is complicated, that has multiple factors that are affected, but you're trying to kind of fit it into something linear. So this is why I was asking, because in this case, we have a lot of things that would contribute to the, the efficacy of the PMTCT. So this is why I was asking about the theory of change, because sometimes we use it in the second scenario where you're trying to summarize a complex problem and maybe in multiple embedded studies and create like a linear fashion of like saying, okay, so we have a budget of X and Y and we triple it, then we will see the results, in multiplicity. So sometimes we use it in this context. So this was my reasoning when I was asking about the theory of change.
Oh, yeah, no, exactly. And I think theory of change as a concept has really been gaining traction, and different people have been referring to it differently. It is a very important tool in organizational development. But I would venture to say that there is no simple system, right? Like my grandfather used to say something like, there's an easy answer to every problem. It's just not the right one. You know what I mean? There's always sort of more going on than one would think. But yeah, I think the elements of theories of change, understanding why, like what our systems are actually composed of and how they're actually working. SIA can help us get to that element. Particularly, I mean, the cascade is one tool, right? And a lot of times people fixate on the cascade, but the process mapping part of SIA is really oftentimes the most powerful, because as the the front care team, the frontline healthcare team draws out this map of how patients pass through their system, what they realize is that different people on the team understand patient flow differently. So some people think patients do this and other people think patients do that. And then usually there's a bit of hearty discussion that occurs, sort of poppy discussion when people start to understand that they're not doing things the same way. And in terms of quality improvement, having people do things in the same way is one of the most important tenets of providing high quality care, right? So that also leans back to the theory of change, because there's multiple ways people are understanding and doing things. And so that mapping together creates a real bonding experience for the team as they actually learn to listen to one another, not just in their words, but on what's on paper, as they draw it out. But thank you so much, Elizabeth. There's some raised hands. I don't know. I think you can. Oh, hi, Ruth.
Hello, how are you?
Nice to see you. I finally figured out how to see the participants. Yeah, there we go.
Thank you for the excellent presentation. I just want to reiterate how valuable this system is. The Kenyan data you saw on PMTCT was that the study was going on at the time when devolution was taking place, and many of the individuals who had been first trained were actually relocating to different health facilities. But because the process involves all the players, that whole process of process mapping and an understanding of how the cascade works, the benefits of it were actually sustained even after people had moved on to other places. So it's a powerful tool in terms of building ownership and standardizing practice within a facility.
Thanks, Ruth. I mean, I tend to agree. I mean, we've had, it's interesting how it's adapted and evolved. And on that previous slide where we see where the PMTCT space is certainly the place where it's built out the most. We have entire provinces in Mozambique where SIA is used in every single antenatal care, maternity, and postpartum care. Like it's used. And it's also using the PCAT, so it also uses the phone-based app, so the frontline healthcare workers can actually look at the data themselves. But it's really the coming together. I think, especially in light of COVID, and thinking through what makes the SIA work, which is a lot of what my work is at the University of Washington, is creating space for people to be together to explain how they think their services function. It seems so basic, but providing that space is so important. And we have that space. We have our, clinical meetings. We all, there you always have, a certain period of time, typically every day, but sometimes just once a week, depending on the system, or at a minimum once a month. And then using these tools to help structure that time in part can be really powerful. Yeah. Does anyone have any ideas for other adaptations that they've been thinking of clinical areas or places where they think this might be useful? Oh, I've got a hand. I see a hand. Wow, there's so many people. I had no idea there's so many people here. I would have been nervous.
Maybe as somebody thinks about it, I would want to just share that some of the other cascades are a lot more complex. We tried to develop a care cascade for children. So testing the children coming in, we have a guideline that children coming into the outpatient services or inpatient should be tested. to be able to identify HIV-infected children early. And as you saw, the care cascade relies on routinely collected data. And we actually found it a challenge to develop a care cascade that works, because the different registers what we use for collecting data are not consistent, and the cutoff points in terms of age group are different. So, for example, the or over age, the maternal child health clinic is whether you are under 5 or over 5 years, and so with this kind of varying cutoff points, it was very difficult to actually get a denominator that would allow us to see accurate care cascade for children, particularly the testing, identification of the to allow for early track and early identification of HIV-infected children. And so, it's a great program, but sometimes you may have to get some adjustments on how you collect data to be successful. Yeah. Thank you.
Yeah, no, there's a great complexity. Some of them work better. I will say hypertension works very well. That cascade was definitely the easiest cascade to build. And it's really pretty easy to see. The hard part, of course, is getting the controlled hypertension at the end and, you know, making those data systems work. But that cascade was actually pretty neat. The cascade working within jails for adolescents in the US is really complex.
Sarah, I wanted to ask, so when in all these scenarios, what was the beginning? Did it start with the health workers in the clinics or in the field, or did it come from mid-level, or how does it really work, comparing, you know, the ground, the mid-level versus the hospital management?
Oh, so in terms of, there's sort of two questions there. One is, you know, how do you get a group of people to buy in to try to use SIA for a specific care cascade? That's sort of the political element. And the other is, how does the work get done? And for the first, I would say, I generally, when any of us are, sometimes we're approached after talks like this, and sometimes, for instance, during the height of COVID and we weren't allowed to travel, and I didn't get a, you know, other than working in the hospital, you know, testing and so forth for COVID, I wasn't getting work done. So that's when I went over to the juvenile detention clinic, which is near my house, and I got an audience, and I said, hey, we're doing this, would this help you? And they were very enthusiastic. So that's how that work began. So sometimes it's just initiation of the actual investigator. Sometimes people have heard about our work from different areas, and then they come and ask us if they can apply for it, or if they've read some of the papers that we've written on it. So that's one way. In terms of getting it to work, SIA is based and depends on the full engagement of the frontline healthcare team. So it's really the clinic manager and his or her staff engaged with us that make the process mapping. And generally, you know, buy-in can be variable. Sometimes in the beginning, maybe some people will be more involved than less. Generally, over time, we get more and more individuals engaged. But it's making sure that you have the frontline in PMTCT. You know, the nurses, generally, some pharmacy representative is very helpful if there's sort of an activist type role that's corralling or educating patients in the wait room, for instance. You know, you'd want all of those people involved, including the clinicians, as possible, right? Yeah.
Thank you. We'd want to hear from Francis Jeru, who's manager at NASCOP PMTCT. Francis, just unmute yourself.
Okay.
And if you want to share a few slides, that's okay, if you're able to. And please go ahead.
Okay. Thank you. I hope, Doctor, you can hear me, Dr. Marwa.
Yes, we can hear you.
Yes.
Very well.
Okay. Thank you very much for the opportunity, and sorry for the technical issues that we had. I really take this opportunity to really give a brief about EMTCT and also say that this is a great opportunity for us as a program in terms of feeling of how we really need to do things differently, and also in line with our key strategic shift that we are really trying to see how we can be able to redesign the program and also be able to how we can also be able to do things differently. I think for us as a program, I may say that beside the science, beside the partnership that we have been having, and also the technology advancement that is there, I may say that in review of that, we are still struggling with the elimination of mother-to-child transmission as one of our key priority as a Minister of Health. I may also say that currently the key rate that we are working on is really below the elimination goal that we have of 5%, is currently at the reported of around 8.3%. For me, one of the key questions that we have is where is the failing goal for all this? We are looking at issues around, are the adults the ones that are making us fail? Is it a system issue? And really, is it acceptable for us to be at that level for 19 years or more in terms of this program since we initiated this? So for us, we are looking at it as as one of the tool and model that we really be able to adapt for us to do things differently and be able to identify the systemic gaps that are there, the barriers, and be able to see how teams can be able to work together to, one, be able to utilize the resources that are available, and also see how they can also be able to utilize the data that is there. This is a great space for us to be able to ensure that we can have support for the children that are voiceless. So we really need now to focus on issues around how we can be able to ensure that our target is mainly for the voiceless as a program, looking at issues around the frameworks that are already existing, see how we can be able to come up with the best tools and models that can be able to support the operationalization of that, looking at issues around integrated health services, and also looking at how robust partnership can also be one of the key components that we can look at. But for us, as for the presentation that we are working on today, systemic analysis will be very important for us so that we can be able to identify the best approach for this program. Currently, we are working with UNICEF in terms of looking how we can be able to implement the last mile interventions, looking at how we can also be able to use that model together. What we have been able to do is that we have been able to have a sensitization meeting in terms of understanding that model of last mile. But what is very critical for all of us is to look at what works best for us as a program. So for me, the dialogue that and the discussion that is there is for us to see what changes can we be able to make, and also what direction can we be able to take to ensure that we are able to re-energize our energies and also be more focused, as also be able to take actions that are relevant for the program. For us currently, we believe that we are working with the counties. Today we are having a stakeholders meeting. Tomorrow we'll be having a PMTCT stock taking meeting to really able to look at areas around where are we in terms of the geographical landscapes, and also the population, and also counties that are left behind, especially the ASAL counties, and looking at how we can also be able to come up with the universal comprehensive interventions that are focused on targeting the key populations that we feel are left behind. That's the children, the AGYW, and the adolescents, and also looking at how private sector would also be one of our drivers for this, and also the vulnerable population. So for me, to this is that the take-home message is that for all of us as a program, we will be able, and I know currently we have a number of our program managers who have also been able to log in to really be able to look at issues of the that can really be able to assist the success of this program in terms of identifying areas that we have the missed opportunities, in terms of identification, looking at areas around putting our people, both mothers and children, on treatment, diagnosis as one, and also areas that we are really suboptimal, whereby we feel that key sources of infection can also be able to be identified, and also the strength to linkage to treatment and timely areas around HIV prevention services can also be looked at. So for us, this is an opportunity for us, and we will take it. And I know we have been able to discuss this with counties, and a few counties have identified this as one of the models that they will be able to really adapt for the county to be able to spearhead the program moving forward. So for us, we are excited, and I really appreciate the discussion, and we will be able to have a further discussion to see how we can be able to implement this. I really appreciate also the support that we are getting from Professor Duarte. We are also with her in our stakeholders meeting discussing areas around EMTCT. Tomorrow we will be able to look in depth the EMTCT component, and one of the key areas I know that will come up is what is new, and what can we be able to do differently, and what are the areas that we can also be able to focus in terms of our investment looking forward. I may also say that for the program, operational research and implementation science is one of our priority for the support that we are requesting from CDC. So moving forward, some of these areas will also be able to be supported in one or another as we move forward. With that, thank you, and over to you, Dr.
Thank you very much, Francis. I'd like to read a comment which is just coming from Felicitas Makoha, which I would kindly ask you to respond to, and also Prof. Duarte could respond. And the comment is that the EMTCT cascade has many challenges that make achievement of elimination elusive. And for one, the program is donor dependent. Early infant diagnosis and ART prophylaxis are affected by commodity stockouts, no EAD filter papers. Health workers have to prioritize and leave some babies not tested. And the comment is about taking charge of commodity security. Please comment on that. Thank you. And also, Prof.
Thank you, Dr. for that comment. I think, as you have said, currently, I think we have one of our key gaps is actually commodity security and sustainability is one of the areas that the ministry is looking critically to see that in the future this would not be able to happen. As you say, is currently that we are more of donor dependent, but one of the key things we have been able to do as a ministry is a cabinet discussion around how we can be able to increase our domestic financing, and also see how we can also be able to ensure that we have a good transition framework moving forward, and also see how we can also be able to work with counties in terms of collaboration to ensure that the investment that is coming forward, some of these key areas may be of priority. So what we have been able to get from the ministry, we have been able to get additional funding to support our commodities moving forward. So some of the priorities that are there would be that EMTCT and other areas, especially EID, is one of the areas that is priority, but not only for this population, but also for the general population, including the ART drugs. So for that, I think, is one of the discussion why we have this meeting with the stakeholders, and also the ministry being here, and also secondly, why we'll be having that meeting tomorrow to come up with a catch-up plan, and also a work plan that can also be able to be presented in the ministry. Here we are headed by our director, who is also taking this as one of the challenges in terms of the achievement of the program. We have also been able to highlight in the discussion that we had with the Professor Duarte today, that commodities are very critical, is one of our pillars for the success of this program. So moving forward, we will be able to look at it as one of our priority in terms of the investment and also domestic financing that we are really encouraging. I can hand over to Professor maybe to have a comment beyond that. Professor,
yes, thank you very much. Prof. Duarte, as I invite you, the time is actually up, but I'd invite Prof. Duarte to make just closing remarks, respond to what you may, and to thank Sarah very much, and also Jero and all the participants. Prof. Nduwati.
Yeah, thank you very much, Prof. Omalo. Just to say that what Dr. Dwega has described is what is going on. I think one of the concerns is that there's an expectation that there will be many changes in the leadership. At least 20 of the counties will have new leaders in terms of governors, and with that will also come other changes. So there are concerns about the stability of the programs during that period of time. So part of the work that's going on here is to identify the vulnerabilities, have a plan of action, work with the people who we know will be continue to be stable employees of the county governments to ensure that there's stability even during that period of time. But I think the important thing is that people are aware of the challenges and they're planning for it. And tomorrow when we discuss, I think we'll talk a little bit more in detail about the use of the SIA approach in strengthening our PMTCT programs. And so I'd say thank you very much, Sarah, for that presentation. Really, it's really good. And I would say to the people who are participating that the PCAT is actually available on Google Store, and you just need to Google and be able to, you get it. And it has been set to follow the Kenyan Cascade. So it's actually easy to use. Thank you.
Thank you so much, everyone. It was a pleasure to be here.
Thank you.
So, thank you very much, Prof. Omalo, for having chaired this session. Thank you.